So thank you very much for having me and for the awesome introduction. So I'm going to talk today about one of the sort of the major components of my PhD, which is a project that we call AERO, which is Ambulance Emergency Response Optimization in developing countries. So there is this work has been submitted to the Operations Research Journal. So there's a copy on arXiv if anyone wants to check it out. You can just Google the title and it should come up, hopefully. So before I dive right into the work, I just want to give you a sense of what sort of my research vision is and the type of work that I do. So as Nan said, it's really combining optimization and machine learning to improve the quality, access, and delivery of healthcare. And for me, I'm particularly interested and get excited about applications in developing countries. And there's really two reasons for that. One, I think as sort of OR people, we have lots of opportunity to contribute there and sort of make a real impact. And then on the other hand, I think there are a lot of interesting challenges faced by the problems and the people in those countries that are slightly different from what we see in North America, and that can lead to new theory and sort of new angles on problems. And so I hope and I think that today's talk is basically going to demonstrate exactly this. That's sort of the plan. So we'll jump right in. So for context, time-sensitive medical emergencies are responsible for over 1/3 of deaths in low and middle income countries. And an example of a time-sensitive medical emergency is something like a cardiac arrest, motor vehicle accident, or some maternal health issues related to childbirth as well. And so in the last decade or so, researchers and many big international organizations like the UN and the WHO have stressed the need for increased focus on these types of emergencies, and in particular on emergency medical care, which treats these types of things. And so really one of the core components, or one of the major components of emergency medical care is this idea of transportation. Right? And transportation, when we often think about it in North America, it's really ambulance services or reaching the patient and providing healthcare to them in some way. And so this is going to come up throughout the talk, but in Bangladesh, we're thinking of transportation at a bit of a higher level, so not just ambulances, but quick response vehicles and things like that. So that'll come back later. Now, if we look in the medical literature, there's actually widespread empirical evidence that introducing an ambulance system or an emergency transportation system saves lives. So a really concrete example that I like to use is in Sierra Leone, they introduced an ambulance system. It doubled utilization of the healthcare system, and it reduced female mortality by 50%. And most of that was related to maternal health issues, right? So those are big concrete numbers. Now, if we look at the sort of the literature in the OR community, ambulance stuff has been done since the beginning of our field, for 60 years, if you will. And most of the work, or basically all of the work of in that area, can be chunked into three groups. So there's been a lot of work that does, urban areas in high-income countries. So think Boston, Toronto, New York. There's quite a bit of work actually on rural areas in high-income countries. So think rural health clinics, hard-to-reach areas, maybe up north in Canada, or sort of out in the west in the U.S. And then there's actually been some work, although quite a while ago, in rural areas in low-income countries, and a lot of this was actually done in South America and Central America. But what's really missing here is there's been almost no work on urban areas in low-income countries. So think megacities like Dhaka, like Mumbai, Karachi, these monstrous cities, and there's been essentially almost no work in that area. And kind of related to this, and maybe because of this, or that's kind of my hypothesis, is there's actually not really a unified framework or an OR tool for addressing this problem. So there's no framework for travel time and demand uncertainty like we see there. So what do I really mean by that? So when we optimize the transport of emergency patients in a low-income setting, there are some unique challenges that we don't encounter in North America that are just not present. And so two of the biggest ones I'm going to focus on today. So the first is travel times. So first and foremost, route disruptions occur far more regularly in low and middle income countries. They can be due to things like political demonstrations, strikes, climate change related issues like flooding. Dhaka is one of the biggest cities affected by this kind of thing in terms of climate change. And so because of this, traffic becomes much more uncertain. And to add on top, it's not the norm in these countries to yield for emergency response vehicles, right? And so, in North America, when ambulances drive down the street, they put on the sirens and everybody more or less gets out of the way. That's not the culture there. That's not the cultural norm. And so it might be a little hard to see, but there's actually an ambulance right here. So I took this photo when I was in Dhaka. there's an ambulance right here. You can't tell, and nobody's moving out of the way, even though there's seemingly a right? And so this leads to a lot of uncertainty in traffic, and it kind of, there's a need for routing. We need to consider routing much more carefully. And then the other major challenge is, so in Bangladesh and in many low-income countries, they don't have a centralized EMS system. And because of that, they have no historical data whatsoever. And actually just the prospect of collecting data itself is a huge challenge for them because there's no centralized system to do so. And so this leads to a lot of challenges in understanding where do emergencies happen, spatially in a city or in any geographic area. And really the goal of this work is to develop a framework, a decision-making tool that optimizes two things and is tailored for these low and middle income countries. So the two things we look at is where should we locate emergency response vehicle outposts? And so I call them outposts because, again, it's more general than an ambulance base. And it actually doesn't need to be a structure. It could simply be an area to station or park ambulances, like a parking lot or a corner or something like that. So we think about it a little bit more abstract. And then once we have determined where to put these resources, the next question, which often doesn't happen in North America, is what route should they be taking to reach patients? So in real time, when we know where an emergency is, what routes do we take? And again, we're going to basically do this tailored to these sort of uncertainties that are faced in this setting. And so this work is really motivated by one particular place, and that's Dhaka, which is the capital city of Bangladesh. It's about the 5th largest city in the world, depending on what stats you use. It's one of the top 3 most densely populated places on the planet. And when we began this project, there was no centralized EMS system whatsoever. So if you needed to reach the hospital in an emergency, you're on your own. And people take a variety of transportation modes. And one of those transportation modes, interestingly enough, is actually private ambulance services or hospital-based ambulance services. So they do exist. They're certainly that's pay for service. And what's great about, or what's really exciting for me, is that 2-3 months ago, they introduced the first centralized number. So for them, it's 999, which is the same as 911 for us. That's the analogy here. And why is that important is because now at least all of these ambulance services, whether they're private or hospital-based, are coordinated with one number, right? And that's a big challenge because it's a lot to ask someone in an emergency you have to look up in the phone book or on your phone to find out which number you need to be calling. Right now we know there's a centralized number, and so that's great for our work because these are sort of the end users for us. And I'll talk about implementation and stuff a little later. So before we get right into the meat of the talk, I just want to give you an overview of this project because it's quite big. And we're going to use this slide as like a ticker throughout this talk. So there's really 4 sections we're going to look at today. The first section is how do we estimate spatial demand or where emergencies happen without this historical data? And so everything from how do we collect data ourselves and build models. And then similarly, when we started this project, Dhaka had no Google traffic data, right? If you want to look at traffic in West Lafayette, you can go on Google, you can get traffic for different times of day, live traffic if you want. So that didn't exist. So again, how are we going to estimate travel times? How are we going to collect this data? And then once we've got these estimations, how can we combine them and put them into an optimization model? So we're going to basically build some uncertainty sets there, integrate it with optimization, come up with a way to solve this model efficiently. And then for me, the most exciting part and my favorite part of the project is, okay, now we have this decision tool. What insights can we get? What policy questions can we answer? And how can we really translate this into some sort of action? So we'll start right away with forecasting emergency demand. So as I said, that there's no historical data. I mean, if I wanted to do this in Toronto, it'd be great. I would call up the EMS center and I'd be like, can you show me your data? And they're going to have every ambulance trip in the last year, the exact time, exact location, and on all this stuff. So that doesn't exist. So what we did was we administered surveys, 2,800 of them, to patients arriving at an emergency department in 16 of the major hospitals. And so these surveys were administered by physicians, and they included questions like, where did you come from? How did you get here? How much did it cost? What's your chief complaint? What's the emergency? All kinds of things like that. And then we supplemented that with census data from Dhaka. And again, this is just, in North America, this is easy, but the census data that we had to get was not actually digitized originally. So that's a challenge in itself. And so this, on the left here, is a map of Dhaka. And so it's split up into these little chunks. In Dhaka, we call these wards. In North America, we call them census tracts. Same idea. And so the blue wards give you an idea of where spatially the hospitals that we surveyed. Green is all hospitals. Right? And so we tried to spread this out, as best we could throughout the city. And so the first thing I want to share is just, okay, what does the system look like now? Right? What are we starting from, and what are people doing in emergencies? So what we've got here on the y-axis is number of patients. X-axis is the mode of transportation they use to reach the emergency department. And so most common mode of transportation, third, is a rickshaw. For those who don't know, a rickshaw is basically a three-wheeled bicycle cart. Right? And so in emergencies, most people are taking one of those. And then ambulances come in at about fifth place, right? Just around 7%. And one of the major reasons for this is that ambulances are by far the most expensive mode of transportation. So they cost, over $16 for a single trip. Now for us, that seems very cheap, but annual income in Bangladesh is only $1,200 a year. So $16 is a sizable chunk. And in contrast, right, rickshaws are by far the cheapest. You can take a rickshaw anywhere you want to go for, $1. So that's one of the issues. And when I first saw this, when I started the project, I was nervous because if there's no ambulance demand, if nobody wants to take ambulances, then this is sort of moot right from the start. So what we did was we actually dove in a little deeper into the data, and we split it up by life-threatening versus non-life-threatening emergencies. And we see something really interesting. Ambulance demand doubles. So in life-threatening emergencies, the number of ambulance trips doubles. And the number of rickshaw trips is cut in half. Which, when I saw this, suggests to me, or sort of gives the indication that, hey, people recognize the need to take ambulances in life-threatening emergencies. When things are bad, people recognize that they should take an ambulance. So there is some baseline demand and some baseline, utilization there, which is great and exciting. And so how are we going to forecast this demand, and how are we going to estimate where emergencies happen? So this is really the first attempt to do something like this in a low and middle income country. I mean, partly because it's really hard to get data. And so we're really going to develop this methodology, and we're going to focus on forecasting demand for traditional ambulance vans, kind of like what we think of in North America, but also for a locally inspired response vehicle, which I call a CNG response vehicle. CNG stands for compressed natural gas. What this is basically a small three-wheeled motorized vehicle. It has one bed on the back, so you can transport a patient. But because it's so much smaller, it's more nimble, and it can navigate traffic a little better, reach more parts of the city. We'll talk about this later, but ambulances, they're big vehicles, and there's a lot of areas in the city that they just simply can't go to. So this is sort of going to be a theme throughout the talk. Now, what do I mean by demand? What I really mean is the annual number of ambulance trips. So we'll just use the word ambulance for now to make things simple. And so we can break that down, and we break this down into three components. Population times the annual ED trips per capita. So you can think of this as, what is the probability that you need to go to the hospital? And then the percentage of those trips via some mode, so in this case an ambulance. So you can think of this as a conditional. Given that you need to go to the hospital, what's the probability that you take an ambulance or a CNG? So this is basically a mode choice decision, if you want to think about it that way. And this is great now because we can estimate each of these three things with our data, right? We can use our census data to get a sense of the population, and we do this for both daytime and nighttime because Dhaka actually has one of the largest daily workforce migrations in the world. More than 1 million people leave the city every day to work. So we need to account for that in our demand. Now the hardest one and the trickiest one is this annual ED trips per capita. There's no data on this in Bangladesh. So we look to neighboring countries, India and Pakistan, which do have some data. And India, Pakistan, and Bangladesh have a long and complicated history that I don't want to get into now, but there's some similarities in the size of the cities and the types of, culturally there's some similarities, at least more similar than perhaps Toronto or New York for sure. And so we look there and we get an estimate of this likelihood that you need to go to the hospital. And because we're using outside data, we're going to settle on a single estimate for the whole city. We're not going to really get granular for each ward. And then the last component, which I think is the most exciting, is we can actually use some more machine learning tools now. We can use our survey data to estimate this mode choice. And so what we want to predict is which mode you will choose. And the way we're going to do that is we're going to use a logistic regression model. It's a regularized model because we have a lot of features. And we're going to chunk our features into 3 main groups. So we have features that are measures of population, so average household size, male-female ratios, things like that. We've got measures of social status, so literacy rates, marriage rates, things like that. And then we have measures of economic status, so income, what kind of housing you live in, do you have access to electricity or sanitary toilets, and things like that. And so we'll combine those into our model and get an estimate of how likely people are to take an ambulance or any other mode. This can be done for any sort of transportation mode. And so in doing that, we can get each of these 3 things, combine them together, and we get a snapshot or a picture of what demand looks like. And so on the left, you've got ambulance demand. On the right, you've got this CNG demand. And so there's one thing I want to sort of draw your attention to in these figures, and that's this area right here and this blue area here. So for CNG demand, those are 2 of the largest demand areas. Dark blue is high. Whereas for ambulances, they're quite low. And so I was in Dhaka, and I know that these are 2 of the largest low-income slum areas in the city. They're very dense. A lot of people live there. So it makes sense that they're more likely to take a cheaper, more accessible mode of transportation. And this theme is going to keep coming back throughout the talk. So I just want to highlight that right now. So that kind of concludes the first section. Now we have a... Yeah, yeah. Yep. Yes, incidents. So this will be demand. So in other words, in this ward, they're generating somewhere between 25,000 and 35,000 trips per year to the hospital, right? That's what's going on. Yep. Yeah.
I have a question regarding that. So, in some previous slide, I think those blue regions that you are showing right now in the right picture.
Yeah, here, yeah.
You talked about they have hospitals there.
I don't think. So you're asking about here. Yeah, so this ward doesn't quite have a hospital, but there is a big medical center here. That's where like the Cardiovascular Institute is and the Children's Hospital.
Yeah. So now if you go there, so do you have any where all these in public
Hospitals?
government hospitals?
A mix.
Mix?
Yeah, mix.
So did you have a chance to see, because like the slum people, they always go to the
Government hospital. Yep, absolutely.
Free.
Yep.
So did you have a look in that, because that should have a better influence?
Yeah, absolutely. So we're sort of less interested in which hospital they end up at, more that they need to go to a hospital. Because that's sort of the driving demand for ambulances, is you need to be transported to some hospital. Once we pick you up, we can take you wherever you want to go. So for people who are more low income, of course, they're going to go to the government hospitals rather than the private ones. But again, that's sort of like a second stage decision. Now that we've reached you and we can start treatment, where do we take you to? Yeah, absolutely. So now we have this snapshot of demand. The next thing we need to look towards is travel time. So again, how are we going to forecast travel time? So before we get into forecasting travel times, we need to know what the road network looks like. And we need to know what we're forecasting on. So I've got 2 road networks. On the left, I have what I call the ambulance road network. So we worked with the traffic engineer in a big detailed map of the city, and we basically figured out which roads can an ambulance travel on and which roads can they not. And so the ambulance road network is about 530 nodes. Each node is an intersection. The edges are basically the roads between those intersections. And this, you can think about this as the major arteries, right? The major roadways that an ambulance could travel on. And then on the right, you've got the full road network. So every road, alley, street in the city. And so again, this is about 10 times bigger. We've got 5,000 plus nodes now. And if you remember from a few slides ago, we're focusing on these low-income areas. They essentially do not show up at all on the ambulance network because the ambulances cannot reach those areas. It's too crowded. The streets are too narrow. Whereas on the complete network, it's an extremely dense chunk of nodes, right? So there is a lot of people there and a lot of stuff. So again, this is going to keep coming back, and we'll talk about how we address this. So to collect data, again, there was no traffic data, no travel time data, so we went out and we built our own GPS devices. We accompanied them with an Android app. So these are the GPS devices. and we gave them to 5 volunteers, and we asked them to drive around for a month. And so they drove at different times of day, days of the week, middle of the night, all of this to basically capture data. Now, one of the sort of unforeseen challenges of this project was just because you know the GPS points doesn't mean you know which road they drove on, right? So this idea of map matching was actually really hard, and that's a publication in itself. So this is a challenge that you don't often get in cities in North America. They're all grid structures, usually quite optimal. So that was an interesting challenge. And so again, I want to give you a sense of the data. So we collected data for 269 trips. A trip is when the driver turned on the device until they turned it off. Sometimes they forgot, so if the device was not moving for 45 minutes or longer, we just cut it, kind of thing. And the most surprising thing is the average travel speed of a car across all the trips was 2 kilometers an hour, right? Which by far you could walk faster. But again, when I was in Dhaka, I stayed in sort of the north part of the city, and to get downtown in the middle of the day for a meeting, we would have to leave 4 or 5 hours ahead of time in the same city, right? So now this makes sense, actually. It's not sort of that far-fetched. And then we do this sort of trick, if you will. So 269 trips is not a lot, right? And so what does a trip look like? A trip could be something like this. It starts at node 1, traverses nodes 2 and 3, and ends at node 4. So we have 269 of these. So one thing we could do is train our model on trips. Another thing we could do is split all these trips up into edges, just like these first 3, and train our model on edges. Now, there's some issues with both, and what we do is something that I call, it's kind of like a bootstrap approach, and we create these sub-trips. And this is really great for a few reasons. One, we increase our data by 15 times. So what is a sub-trip? We take a trip like this, and we split it up into all its contiguous sub-trips. So the edges, 1 to 2, 2 to 3, 3 to 4, and then things like 1 to 3, 2 to 4, and of course the full trip. So this data includes both edges and trips and everything in between. The other great thing is that most of the congestion in traffic occurs at the nodes. Because they're intersections, Dhaka has very few traffic lights, and even the traffic lights that are there, most people don't care that they're there, right? And so a lot of the traffic you face happens through the intersection, and then in some cases you get to drive fast on the road in between the intersections, then you're stuck again, and it goes like that. So by keeping the trips in this way, we're able to capture some of that congestion in the middle. And the other nice thing here is that when we make our forecasts, we're going to use start nodes and end nodes. And so if we only considered trips, we miss everything in the middle. So if you started in a low traffic area and ended in a low traffic area, but you traversed the middle of the city, we would have lost that information. But by splitting this up, we're able to kind of glean some of that and use it. So what does our prediction look like? Well, we're going to predict the travel time between any 2 nodes in the network, and we're going to use a bunch of features. So some are very classic. Distance between the 2 nodes, hour of the day, day of the week, right? Very, very sort of obvious things that have been done before. We're also going to try a few things that haven't been tried before, not even in North America. And those are features that correspond to demographics of the origin and destination, and also building types of the origin and destination. And I think it's important because my sense is that residential, commercial, and industrial areas have different types of traffic, different vehicles on the road. And so we're trying to capture some of that. And then to make this prediction, we're going to basically throw the book at it. We're going to try a host of different models, but we're also going to try some really naive approaches. Because the traffic is so bad, I was wondering, can I just get away with predicting the average every time? Or do I just need distance-only regression, something really easy? And so if we take a look at some results, we've got root mean squared error in seconds on the y-axis, all of the methods on the x-axis, and the colors correspond to what data the model was trained on. Whether I trained it on edge only, which is blue, trip only, which is red, or this sub-trip combined data, which is green. And so in this figure, we tested the models on sub-trip data. I have the same analogous figures for testing it on the other 2. They more or less look exactly the same. So the results are pretty generalizable. And what we see is that the random forest model performs by far the best. These 2 naive approaches do quite poorly. The random forest is able to kind of cut the error in half, which is great. The other nice thing about using a random forest is there's some interpretability there. we actually can get a sense of what features are driving the model. And when I first saw this, I almost fell over my chair. I was so excited because it makes a lot of sense. Most important feature, travel distance. Second most important feature, hour of the day, which is a direct proxy for rush hour. Third most, day of the week. Again, related to rush hour. And then we see a bunch of features related to these demographics and buildings. Interestingly, medical facility shows up as fourth. And so one of the things I wanted to look at, because no one had really tried these features before, is what value do they actually provide? And we can do a model with and without them, and we show we can get about an 8% performance bump, which is non-negligible. And so this sort of concludes section 2, if you will, the forecasting of travel times. And so now we've predicted demand, we've predicted traffic. We need to combine them to make some decisions in optimization. So there's really no, and when we started, there was really no model suited for what we wanted to do. So we came up with our own model, and I call it the network flow formulation. The focus of the model is to determine where to put these outposts. We're going to minimize demand-weighted travel time, locate some number of outposts, make sure we satisfy all demand. Now, I can prove that this model is equivalent to the p-median formulation. The p-median is one of the most classic facility location models. It was invented in the 60s. And by equivalent, I mean if you give me a solution to one, I can construct the solution to the other, and it will have the same cost. So basically, really strong equivalence. The main difference between the two models is that in the p-median, you pre-compute all the shortest paths. And you input them into the model as the Tij parameter. So in other words, you've determined ahead of time all the routes you're going to take, because you pre-computed all the shortest paths. In our model, we don't do that. We allow the routing or the shortest path calculation to happen during the optimization phase. And so this adds, of course, a little bit of computational cost, but it gives us the flexibility to change our routes depending on traffic and depending on how demand profiles change. So that's sort of the motivation behind this model. And as you know, we're going to consider uncertainty. So we're going to take a robust sort of viewpoint. We've got travel time, that's given by C, that's going to be uncertain, and demand given by D will also be uncertain. And we're going to take this two-stage approach. Now, I really think the two-stage approach fits well with this application. So why do I think that? So first, the first stage decision is determining where to locate these outposts. That's a high-level strategic decision we have to make in the face of uncertainty. We're going to make this decision for perhaps a long time horizon, and we don't know on a given day what the traffic exactly will be or where emergencies might happen. So that's a high-level decision made before we know the uncertainty. And then once the uncertainty has been realized, we can make the routing decision in real time, right? It's a particular day at a particular time. I know there's a patient here. I know the traffic right now. I can make my routing choice. And so I think that this is very well suited because it models the situation exactly in this way. Now, one of the big questions is, how are we going to build these uncertainty sets, right? How are we going to construct this uncertainty set from our data? And so this is sort of one of the things that I like and is part of my future research interests. So for demand, we're going to use a scenario, travel time on every edge using our random forest model. And then we're going to basically think of this as allowing nature to add traffic to these edges according to some budget. And so I think this is useful for a few reasons. One, I can use this budget to kind of understand how the level of traffic impacts my model. If I set the budget to 0, there's essentially no traffic, just baseline. If I tune up B really high, that allows nature to add a lot of extra traffic. So really, worst case situations, maybe a massive flood in the city or something like that. The other cool thing here is it gives us some insight on which edges are most vulnerable, right? Depending on where nature adds all of the traffic can tell us, okay, these edges are vulnerable. Or these edges are sort of, if something goes wrong here, that could really affect our routing decision. And so I'm going to come back to this in a couple slides because there's a little bit more insight we can actually get with this type of model. So if I use these two types of uncertainty sets, I can show that I can reformulate that gross two-stage model into a single-stage MIP, linear program, mixed interlinear program. Now, of course, this is extremely hard to solve, especially for real-world size cases, but just looking at it, it kind of lends itself to a solution approach. So what's going on here? K is basically an index for the scenarios. So the first thing when I look at this, I think, okay, do we need all of the scenarios? Or can we just get away with some subset, maybe a smart subset? So that's what we do. That's how we solve it. So we come up with a master problem that only includes a small number of scenarios. And initially, actually, it only includes one. And then we have a subproblem that will add scenarios to the master problem in an iterative way. And so this is great because it basically allows us to solve this model much quicker, and we'll talk about that in a few slides. And so the master problem is going to give us a lower bound, of course, and then our subproblem is going to find, okay, what's the next scenario we need to add? And our subproblem is nice. It's actually a linear programming problem. And more specifically, it's the robust shortest path problem. And I can solve these, in a fraction of a second. I can parallelize them if I want to. So I can get away with solving thousands or tens of thousands of scenarios very quickly. And we have to solve this for every single scenario. So given a solution from the master, we solve this for every scenario. We rank them, find the scenario with the largest cost. That's the limiting one. Add that back to the master problem. So you can basically think of this as row and column generation, because we're adding both constraints and variables. Those are scenarios, right, to the master problem. And we continue in this way. Now, one of the other things I can do is I don't need to pick my first scenario at random. I can choose it smartly. So how can we do that? Well, what's the most limiting scenario? It's the one with the largest demand. Right? If demand is as big as possible, that's going to be limiting for ambulances because we need more of them. And so essentially we could take the 1 norm or the 2 norm of the demand vector and add that scenario first. And if I do it in this way, I've done a lot of experience. I haven't seen this really go past 5 iterations. So it's quite quick. And there's an interesting connection here with this shortest path problem and this interdiction uncertainty set. And so we can actually connect it to a machine learning field, which is this idea of regularization. And so what does that actually mean? Basically, if I use the uncertainty set I showed you with this budget, I can show this is equivalent to L-infinity regularization. And L-infinity regularization gives us some insight on what's going on, because the idea of L-infinity regularization is let's minimize the largest component. In other words, let's minimize the number of ambulances on a single edge. We don't want to put all of our ambulances through one edge, because then if something goes wrong on that edge, we are going to be punished poorly for it. So in other words, this gives us some insight that the model is really trying to spread out the routing to be robust to the traffic. Right? So we're kind of spreading the routing out amongst a bunch of different edges. Now, I can show, depending on which type of uncertainty set I use, if I modify it a bit, I can get the classic lasso regularization or ridge regularization. And so, this equivalence has been demonstrated in regression recently, but it hasn't been shown in the concept of shortest path problems yet. So this is a nice little aside, I guess, if you will. And now, the last thing here is, okay, we got this solution method, that's great, but the complete road network has 5,000 nodes and 16,000 edges. That's a monstrous facility location problem, right? The master problem here is still an IP, and a really hard one indeed. So we come up with the heuristic. There's some good things and bad things. The p-median literature has hundreds of papers on heuristics. So there's a lot to look at. Unfortunately, none of them are directly applicable because our model is not exactly the p-median. It's close, but it's got this uncertainty, and there's this robust shortest path thing going on here. So what we basically do is we use the spirit of some of these historical heuristics to kind of redesign them for our purpose. And so we take advantage of really classic heuristics that have been around for 50 years, which is these interchange ideas and alternate heuristics. So I'm not going to get in the details today, but really what this results in is the first tractable approach to solve this kind of problem. I mean, again, I'm cheating a bit here because no one's formulated this model yet, but we come up with a tractable way to solve it for real world size cases. And I'll give you a sense of what our solution times or optimality looks like. So on the left, we've got optimal cost and then increasing problem size. So different numbers of scenarios is each of these groupings. And then within each grouping, if we turn up the traffic budget, that makes the problem a little harder. And so really the takeaway from this graph is there's no obvious pattern. Right? Our heuristic is not suffering in specific cases. And the optimality gap is between 8 and 10% on average, which, depending on how you feel, is good or bad. Right? So we can talk about that after for sure. And then on the right, we've got solution time. So again, same idea, increasing number of problem size. The black line is the MIP. If I just take my MIP as it is, send it to Gurobi or Cplex, it explodes, right away. And in contrast, my optimal scenario generation or my heuristic scenario generation, can be solved very quickly. And in fact, all of the problems we're going to see in the next policy section, I can solve them within 15 minutes. Okay, so there's a real-world facility location style problems. So that kind of concludes this section. And to summarize, we've got a model. We've got a way to solve this model for real-world cases. So now we want to use this decision tool to actually get some insights, make some recommendations, and sort of, do some real stuff, if you will. So this is my favorite part of the project because I really like applied healthcare stuff. So hopefully you find it interesting as well. We're going to look at 3 policy questions. The first is, should we use different outposts for different times of day or days of the week? We do that in North America for ambulances. We relocate them. Does that make sense in Dhaka? And then there's already some baseline situation in Dhaka because there are ambulance services there. How much can I improve it? First of all, what is the baseline response times? And then how much can I improve them by? Different strategies. And then lastly, this idea of these CNG response vehicles, what value do they really have? No one in sort of the medical or OR community has really quantified this. There's been medical papers that have suggested, smaller vehicles are more nimble and they can get to people faster, but how much faster? And what's the real value? So the first thing we're going to look at is 3 snapshots, 3 different daytime combinations. So rush hour, Monday at 6, overnight, Monday at 2 a.m., and weekend, Saturday at noon. And what we've got here is we've got average response time, each of the 3 times of day, and the colors correspond to what the model was optimized for. So green means that we optimized the model for rush hour, and when we tested on rush hour, average response time is at 47 minutes. So the first takeaway here is average response times during rush hour versus other times of the day, 30 minutes longer. So rush hour has a huge impact on travel times. The other big takeaway here is if we use rush hour locations during rush hour, we see a big improvement, about 10 to 12% in response times. But if we use rush hour locations for other times of day, there's very little loss. And so this is an important result because it suggests that ambulance providers do not need to optimize their outpost locations for different times of day and the days of the week. They can just use rush hour all the time. And this is an important takeaway for a few reasons. One, it reduces system complexity. So the ambulance service is already stretched. They don't need to manage all these other locations. They don't need to worry about a complex repositioning policy. And so there's actually literature out there that shows that in low and middle income countries, simple solutions are more likely to be implemented. And it's great in our case because simple is optimal, right? So it's kind of a win-win for us. So now for the rest of the experiments, I'll only look at rush hour. So next what we want to do is we want to say, okay, what's the baseline right now? What are things looking like? So there's 67 hospitals with emergency departments in Dhaka. Each of those hospitals is affiliated with either their own ambulance service or some private service. And so we can get a sense of what response times look like, and then how can we improve these? Should we be repositioning outposts? Should we add new ones? Or should we just say scrap what you have and start from something brand new and fresh? So there's a lot here, and I'll draw your attention to a few things first. So the first column in both this one and this one is the baseline response time. It's about 43 minutes. Okay, so that's the baseline response time. Now, the next thing I want to draw your attention to is that whether or not we reposition one, add one, the first additional resource makes a big jump. But then we quickly see diminishing returns. Right? So that's the first takeaway here. The second is that these 2 graphs have the same y-axis. They look almost identical. This one is just repositioning current resources, and this one's adding new ones. So the takeaway here is that we don't need new resources. We just need to use the ones we already have better, which again is great because this is a resource-limited setting. And so, for comparison, whether we add 10 new ones or reposition 10 current ones, it's essentially the exact same. And then the last thing I'll sort of draw your attention to is this figure, which is what if we scrap the current system altogether and start fresh? So the current system has a response time, here, about 45 minutes. If I create a fresh new system with 20 locations only, so less than a third of the resources, I can get the exact same performance. So again, this suggests this idea of we just need to better utilize the resources we already have. So let's look deeper into this 20 right here. What is it spatially, what's going on here? So the pink nodes are 9 outposts or 9 hospitals where we will keep ambulances. Nothing needs to change. The yellow nodes are new outposts, or basically places we are going to reposition some of our resources to. And the blue nodes are the 47 hospitals that essentially we can remove the ambulances from them and use them in these other places. Yeah?
I just wonder if you looked at using the river as for ambulance traffic.
In Dhaka?
Yeah.
You could, although the river is really only here,
Yeah,
right?
that's
So
true,
we kind of lose most of the city, but you could use like a
One node.
like a boat ambulance if you want. Yeah, you could certainly look at this. We didn't, but you could, yeah. And so, few things I should mention here. Again, we've got only 20 outposts that we need, but we're locating 2 new nodes in this area, which I know has a lot of low income and sort of demand. And we're keeping one right here, which again is very near this sort of big low income area. Now, this is great because, you know, it looks like we're sort of improving equity and access, but we're not really. We're not really reaching those people inside in the slums. Okay, so the takeaway here is the current network is a completely dominated solution. We can get equal performance or even better performance with no new resources added, just repositioning them. But for me, we're really still lacking the ability to reach these people who basically need the help the most. So that's where this idea of these CNGs comes into play. And so there's 2 hypotheses that I have with these CNGs. On one hand, because they're able to reach all of the city, they should be able to capture more ambulance trips. Okay? The second hypothesis I have is that, again, because they have access to the full road network, they should be able to mitigate uncertainty better because they have more routing options, more flexibility. And so we think that there's going to be some gains there. So let's look at these things. So first, what am I thinking about when I say potential ambulance demand lost? So let's look at this. So green nodes are nodes that an ambulance, a traditional ambulance, could visit and capture that demand. If somebody needed an ambulance at a green node, we can get to them with an ambulance. All the blue nodes, we can't. So if somebody is at a blue node, they need an ambulance, we can't reach them. We can reach them with the CNG. Now, for me, in an emergency, it seems like a lot, and I think it's a lot to ask somebody who's maybe here to, okay, find your first mode of transportation to get to here, wait for the ambulance there, and then we'll take you to the hospital. That's a lot to ask in an emergency, right? The coordinating trips like that, that's tricky. So we're basically going to assume if you called an ambulance here, you're not getting it. It was lost. But it could be captured by a CNG. And so if we quantify this, the CNGs are able to capture 500,000 trips more a year. That's over 3 times what ambulances could capture. And essentially that's solely due to their ability to reach low-income areas because they're smaller and nimble vehicles. And then at the same time, because they have more routing options, they can reduce response times by 42% with no extra resources added. Simply a vehicle change reduces your response times by 42%. That's both in the median, the worst case, and it shrinks the variance. So it is actually mitigating uncertainty better, right? It is sort of protecting against bad situations and things when they're really bad. So the last thing that I was interested in is, okay, should we station the CNGs and the regular ambulances at the same place? Or not? Because that's a very operational question that you would want to know, and the answer is no. You need to find different locations for traditional ambulances versus CNGs. And so I've got a figure here. The pink nodes are ambulance locations. The yellow nodes are CNG locations. And the blue ones they have in common. So they have 4 out of 20 in common. The rest are new locations. And so again, we've got locations happening here. We've now got a location happening in this low-income area here, and we're able to access sort of these people. And so for me, this is great because these CNG ambulances have the potential to improve efficiency and improve equity and access, which is very important. Now, operationally, the outposts that we would choose for CNGs versus regular ambulances are very different, which again is an important thing to know. And then thinking ahead, I'm going to sort of transition to more implementation now. This is great, but in order to realize these gains, there's a lot more that has to happen, right? We need education and awareness campaigns that will accompany this type of work to basically make a cultural shift in the sense you need to teach people to call 999. So this is something we take for granted in North America. Kids as little as 2 or 3 years old know how to call 911, and sometimes they do by accident, right? That's not the culture in Bangladesh. So this is a big challenge culturally. And so in terms of implementation, we're working with, if you remember at the beginning of the talk, I mentioned this new 999 number that started up a few months ago. That was started by the Critical Link Foundation. So in Bangladesh and in India, actually, EMS services are offloaded from the government. So they're actually run by a private corporation, not by the government like we have in North America. So this Critical Link Foundation is responsible for the 999 number. They've actually developed an app-based response system. So in other words, you can call 911 from an app on your phone. The reason they developed this is because addresses in Dhaka are a nightmare. And if you use your phone, I can ping exactly your GPS location and know where you are. So I can get to you. And one of the things Critical Link is currently doing is building response outposts. And they're thinking of outposts even more general than I'm thinking of them. They're thinking of them as places that first responders can go and hang out. Ambulances could park. CNG vehicles could park. They could do some training there. And so we're working with them. It's a give and take thing on where they should be building some of these and where shouldn't they. And of course, that's back and forth because maybe some areas there's no land or there's political issues. So that's a back and forth issue. And then in India, I'm working with the Emergency Management Response Research Institute, which is the analogous organization. They have developed India's number, which is 112. It's more in line with the European system. This has been well established. They've been running for over a decade. They've got great data. I'm going there in April to kind of keep working on this, and I'm very excited because they have so much great data. It's a lot less of a challenge. So this really kind of wraps up the talk. We've, to summarize, we've developed this comprehensive framework tailored to the challenges faced in low and middle income countries. We used it to get some practical policy insights, make recommendations. And then for me, more personally, I really think this highlights the opportunity of combining optimization and machine learning to solve a relevant healthcare problem, a real world healthcare problem. And so before we go to questions, I just want to give you a little sense of some of the future ideas that I have and some what a lab might look like or what my lab might look like. So in terms of healthcare, I've got lots of ideas. Of course, I'd like to keep working on emergency medical response. So another portion of my thesis looks at using drones in this setting. So the first project we did there was using drones to deliver defibrillators to cardiac arrest patients, right? But there are plenty of other applications, I think, of drone resources, whether it's delivering trauma kits to motor vehicle accidents in India. Motor vehicle accidents happen 1 every 4 minutes. Whether it's delivering medical supplies to rural areas that are really hard to reach, whether in North America or, again, in developing countries. You could even use them to deliver resources between hospitals in big cities that are traffic congested, whether it's blood or organs. And then I mentioned, so I'm going to India in April for 3 months. I got a grant to go work on a diabetes management project. I'm working with the prof from the Indian School of Business and an organization called NanoHealth. They won the Holt Prize a few years ago, so it's sort of a Nobel Prize for social good, if you want to think about it that way. So I'm really excited about the opportunities there. And then thinking long term, I've got some ideas of sort of in personalized medicine and leveraging EMR and EHR data to kind of help doctors, as decision support tools for them basically to access all of the patients they've treated on demand and kind of get a sense, basically leverage their memory, which is stretched quite thin because they're doctors and they're very busy. And then methodologically, which is very important, my work is sort of at this machine learning optimization integration. So in this project, we made predictions and we combined them with optimization in a pretty ad hoc way. But I think there are a lot of questions on how to best do this. How can we best take predictions and integrate them with optimization? Can we get some probabilistic guarantees on some things, bounds, maybe on optimal solutions and error? So I think there's lots of questions there. And then on the flip, I think there's lots of questions on making optimization decisions and then predictions. So this happens in healthcare a lot because we'll optimize for response time and then we'll say secondly, okay, response times of this should save this many people. But really we should be doing that together. And so I think there are a lot of interesting questions on on combining these models. So most machine learning models, once they've been trained, can be formulated as integer programming constraints. So we can easily integrate them into the optimization framework. A really simple one is if you take a linear regression, train it, you can pop it in the objective function right away. Right? So there's a lot of, I think, questions there. And then I think a lab for me is I mean, at Purdue is something between the Archie and sort of the Timmy Global Health Institute. You know, I think kind of in between in these types of areas. Of course, you can probably tell my research is very collaborative. It's interdisciplinary. I like to work with people from, you know, BME, computer science, of course, industrial engineers, public health, you know, other healthcare professionals. I work with hospitals in Toronto as well. I mean, I like mentorship, so I'd love to train students at all levels, undergrad through postdocs. I mean, I'm sort of passionate about that, and I think this type of research lends itself well to funding. Certainly methodologically, NSF would be a target for some of this. Machine learning optimization is very hot these days, so hopefully they're into that. This project was actually funded by Grand Challenges, which is a Gates Foundation thing. So I think there's opportunity there for some of the drone work. I've been looking into USAID for some diabetes management funding because it's kind of one of their target areas these days. So I'll stop talking now. Thank you for listening. Happy to answer any questions. Yeah, thank you. Yeah.
First of all, thanks for introduction in Bangladesh. So I can see lots of other issues or features that maybe some of them has been distorted because of complexity and other things. First of all, Uber is now in Bangladesh.
Yeah, I know this. Yeah, yeah.
So there are a couple of
And Google has traffic data now too.
right,
I don't know if you knew that. Yeah.
recent changes in terms of data and in terms of policy. So number one is that one. Number two is for CNG. The main problem is the wait time to get the CNG because it's dependent on the driver's mentality that whether they want to go or not, though they are bound to go. So there's this fiscal barrier. But as a result of implementation or introduction of Uber, now there's a new app that has been started for CNG drivers.
Yep.
But another issue is these apps are available only in phones that are normally not used by strong people.
Yeah, yeah.
That's a challenge.
Yeah.
And there is this equity ruling from the High Court that says like all the patients, all the hospitals are bound to treat, even if they don't have the monetary ability.
They can't turn them away. Yeah, yeah.
So I think all these features and issues can be included or discussed in some way to make this whole idea a better one.
Yeah, absolutely. So that's kind of one of the interesting things is things are changing so fast in Bangladesh that from the start of this project to the end, a lot of this has happened. So I think there are a couple. I think Uber is an awesome resource that we could kind of leverage in some way. I mean, it'd be great if all Ubers had like first aid kits in them. We basically just built a bunch of responders all over the city if we do that, right? Same idea with maybe rickshaws or something. I think there's some incentive. So the one interesting thing is that most of these ambulance providers, they're for profit. So my sort of pitch to them is, look, if you use our model, you can make more trips, which means you're going to make more money, right? And you're helping people too at the same time. If we can reduce response times, you'll make more trips, you'll make more money, and so hopefully there's some incentive for them to kind of get on board. I think the hospital thing is great, because so this is one thing I sort of was upset about when I was there, is that they could turn patients away. If you come to the ED with an emergency, they could say no. So that's a thing I think it's been resolved. I didn't actually know that, but that's great. Yeah. Yeah, yeah.
I wonder in the research on demographics that you did, whether there was any attempt to capture whether the demand, because it's always a demandee on behalf of somebody if it's an emergency situation, was typically for males or females, or if there was any bias in that use of ambulance.
Whether the demandee was so.
Was, for example, on behalf of a man or a woman, is there a bias in providing that kind of service for women?
Yeah, very interesting. So I don't quite have this data. I don't actually know who called the ambulance. I just know who the emergency happened. But one of the things that we did notice is very different from North America. When people arrive to the hospital there, they don't just arrive man and husband, or I mean man and wife, or something like this. It's like 6 to 10 people coming with them. It's like the whole family or like the neighbors. It's kind of a different thing. So that's an interesting challenge too, because they all want to go in the ambulance. But yeah, we don't have the exact data on who hailed it, but this is, I think, a interesting issue.
Not who hailed it, but, I mean, was the patient a male or
Oh,
is there bias in providing those kind of services for women?
yeah, so I do have that data, and I think it's fairly balanced, at least in our sample. But I mean, there's a lot of bias in our sample, of course, because we only surveyed 16 hospitals, we only surveyed for a few months of the year, so I can't say conclusively that
I'd
there's.
just like to look whether there's some
Yeah,
gleaning additional.
Yeah, I will definitely check this because I know whether they were male or female, so I'll look. And maybe there's like some spatial dependence on males are coming from this area, females are coming from this area.
Or, and just the gender biases that exist in many parts of the world.
Yeah, and
Providing defensive services.
yeah, certainly in Bangladesh as well, I think. Other questions? Good.
We're running out of time, so I'd like to thank Justin, and if you have more questions, I'm sure he's
Yeah, happy to talk.
talk to you. All right, well, thank you so much.
Thank you.